Hi everyone, my name is Cassandra Tootin and I'm the Special Projects Coordinator here at the Rosalind Carter Institute in Americus, Georgia. And I'd like to welcome you all to the Screening for Substance Use in Older Adults webinar. But before we begin, I'd like to introduce our presenter today, Jocelyn Chen Wise. Jocelyn is the Program Director of the Fuqua Center for Late Life Depression at Emory University, Division of Geriatric Psychiatry in Atlanta, Georgia. In 2010, Jocelyn joined Emory University's Fuqua Center for Late Life Depression, a nonprofit organization dedicated to increasing access to treatment and awareness of late life mental illness in order to eliminate stigma and discrimination experienced by older adults. As program director, she provides support for community projects, particularly with low-income seniors. As a licensed clinical social worker, she also works in the Emory University Psychiatry Outpatient Clinic, providing education, brief counseling, and connecting patients and families with community mental health and aging resources. Since 2010, she has collaborated with the Emory Alzheimer's Disease Research Center in their support groups for persons experiencing early-stage memory loss and also their care partners. Jocelyn received her Master's in Public Health and Master's in Social Work from the University of California, Los Angeles. Both her public health and social work training have focused on gerontology and working with older adults. And at this time, I'd like to turn it over to Jocelyn. Again, we'll be listening to Screening for Substance Use in Older Adults. Jocelyn?
Thank you so much, Cassandra. I'm very happy to be presenting today on screening for substance use in older adults. And as I've said before, I just believe it's so important to screen for issues around mental health and substance use because they have such an impact on someone's overall health. And knowing about them can help you as a service provider do comprehensive care planning and also set realistic expectations. So learning to ask the right questions and talk sensitively about substance use can open up some very meaningful conversations with your clients. And I appreciate your time, taking time to hone your skills in screening. So I'm going to start this presentation by revisiting a slide that I've shown in other webinars on screening tools. This slide is actually in the wrong order. This slide shows the prevalence of mental health disorders in the general population based on the National Comorbidity Survey, which looked at a national sample of 10,000 people in the U.S. And this data includes substance use disorders as made up of alcohol use, drug use, and nicotine. So even if you include nicotine, substance use is one of the most common of any of the mental health disorders, both in terms of the prevalence in a 12-month period and also over the course of a lifetime. But even if you don't include nicotine use, substance use is one of the more common disorders. It's ranking pretty high, about as common as lifetime prevalence of mood disorders. So for the purposes of this presentation, we're going to concentrate on screening for alcohol and drug use. And remember that people can have more than one of these issues going on at any one time. For example, someone could have depression and alcohol abuse, and someone could be abusing both alcohol and drugs. So that's why the numbers on the chart that I previously showed don't add up to the total at the bottom. It's because prevalence rates are even higher when you're looking at people who have comorbidities. So the purpose of our presentation today is to give a little bit of background on substance use, and substance use is really varied, so we're going to do our best to kind of talk through some of the most common issues and the issues you're most likely to see related to older adults. We're going to go over two screening tools, the CAGE aid and the audit. And we're going to talk about how to administer the tools, how to score, and then we're going to go through some frequently asked questions about the tools. So the goal of today's presentation is to help you feel comfortable using the CAGE aid and the audit to screen for, oh my gosh, sorry, there's a typo here. It should say substance use, not for depression. But we also want you to just feel equipped towards taking the first steps with helping someone identify their substance use and seek further assessment. So what is substance use? When people think about substance abuse, they often think of alcohol abuse. And that's because, as we saw in our previous prevalence slide, alcohol abuse is the most common of the substance abuse disorders. It's also legal to purchase, and it's easy to get alcohol. So usually when we think of older people, we think of alcohol abuse, and we don't think so much about illicit drugs. A very small percentage of older adults are addicted to illicit drugs or street drugs like marijuana, heroin, crack, or cocaine, but there's evidence to show that this will change as baby boomers get older. And lastly, we sometimes don't think about prescription drugs when we think about substance abuse. Now, why is that? Probably because they were prescribed by a doctor, they were filled at a pharmacy, and they were probably covered by your health insurance. So it's perfectly legitimate. But prescription drugs are getting more and more attention and concern from families, healthcare providers, and the government. So we're going to spend a fair amount of time today talking about prescription drug misuse. If you're looking at how different substance use disorders are diagnosed, you'll see that the diagnostic criteria are based on research, and that over time we've become more and more knowledgeable about the nuances of addictive disease. There's great variation in the diagnostic criteria across different substance-related disorders, but there are also some similarities. The symptoms that come with substance abuse usually impact someone's cognition, or their ability to think, their behavior, and also their physical health. So the symptoms usually fall into these categories. The Diagnostics and Statistical Manual 5, the DSM-5, puts the symptoms of substance use into 4 groups. So the first one is impaired control, which may mean that someone is taking more of a substance or drinking more over time. Maybe they've tried to quit and they've been unsuccessful. So their ability to control their behaviors around the substance are impaired. Social impairment refers to having problems at home, at work, at school, and that could be difficulty meeting your obligations and responsibilities at these places, or it could be having problems with relationships with people at home or work or school. The next category is risky use. So that's when people use substances even when it's physically hazardous. So even when someone is very impaired by alcohol, they might still insist on driving. Pharmacological symptoms have to do with what happens in our body physically in terms of how we react to the substance. So people might become more tolerant, so they might need larger and larger quantities of a substance in order to get a high or to get some sort of effect. Or they might experience withdrawal, so when they're having less of it, they have uncomfortable feelings, and they can definitely miss having the substance, and that can affect their behavior as well. So keep in mind that substance use falls on a spectrum. Some people may be experiencing a lot of symptoms and meet criteria for diagnosis of an actual disorder. Others may be having just a few symptoms and problems, and they might not meet criteria for substance use disorder, but they are being impacted by harmful drinking or risky drug use, and that has the potential to get worse. I want to take a moment to talk about prescription medications because they're very relevant to older adults. This slide is titled, "She's Not Addicted, Her Doctor Prescribes the Pills She Takes." So again, this gets back to this idea that it's a legitimate use of a medication that was prescribed by a medical professional, but we'll go through some statistics here that show just kind of how vulnerable older adults can be. So some older adults who become addicted to prescription medications, it happens intentionally. They might misuse their medications purposefully, but for others, it sort of happens unintentionally. And then for other people, it's sort of a combination of unintentional and intentional misuse. So looking at this slide, what we know is that there's an incredible access that older people have to prescription medications. 83% of people age 65 and older use prescription medications. We also know that older women consume 60% of all prescription and over-the-counter medications. And we know that that is a huge overrepresentation. Older women don't make up 60% of the population, but they're using 60% of all of the medicines out there. And the other issue with older adults and prescription medications is that addiction to prescription meds can cause illnesses that resemble problems associated with old age, and they can go unchecked. So some of the side effects of using prescription medications can make it seem like you're having memory problems or balance problems. These are things that can come with aging, and sometimes they just get written off as something that's naturally happening to you now that you're older. So think about a doctor's visit with an older person who has multiple health conditions. And the doctor is in a position where he or she is trying to address all kinds of health issues in a very limited span of time. They have to prioritize the things that they think are most serious and urgent, and they need to try to make some progress around those issues. So unless they hear from the patient or a family member that they're having problems with a particular medication, most of the time they may just keep the medications the same. So imagine your client is on a painkiller that he needed a year ago for an injury, but he's still taking it because he never told anyone that the pain has gotten better or that even that he's still taking it. And maybe he wants to stay on it now because he finds that it helps him sleep. But it's also causing him to have some memory issues and some mild balance problems that maybe he doesn't notice, but family members have noticed. So you can see how complicated medications can become when they come up, and they bring both positives and negatives into your lives. And when 83% of people age 65 and older are using prescription medications, it's just a really widespread issue. So we pay particular attention to older adults for a few reasons. We actually know that older adults are not the most likely people to be abusing prescription drugs. Younger adults, age 18 through 25, are actually the highest abusers of prescription medications. But older adults are the highest users. And we pay attention to them because there are physical changes that happen in older adults that make them especially sensitive to medication. Your metabolism, which is how your body processes things, it changes when you're older, and that's due to changes in your liver, changes in your kidneys, even changes in your gastrointestinal system. And so larger doses of medication that maybe were perfectly fine for you at age 45 are now having a larger impact on you at age 65. We also know that older adults are more likely to be prescribed psychoactive medications for pain, sleep disorders, and anxiety. 1 in 4 older adults uses psychoactive medications, and on the next slide we'll talk about what those are. They're more likely to use them for a longer period of time than younger people. And an estimated 1 in 5, so about 20% of older adults are affected by combining alcohol and medication misuse. So psychoactive medications act primarily on the central nervous system, and they affect the brain and how it functions in terms of mood, cognition, behavior, and consciousness. Some of these medications produce euphoric feelings, so feeling good and sort of up and high by acting on the pleasure center in the brain. Benzodiazepines are usually prescribed for anxiety and insomnia. They're sedatives and they're tranquilizers. Usually they're meant for short-term use. Analgesics or opioids are usually prescribed as painkillers, and these classes of medicines have high potential for abuse and dependence. Remember how on an earlier slide we said that misuse of prescription medications may resemble problems associated with old age, like changes in your memory or maybe poor balance? Side effects that come from benzodiazepines and painkillers, these are the medications that can make someone look like they're having problems in these areas. Maybe what's actually happening is that they're taking too much of the medication, or maybe it's interacting with another medication they're on, or maybe they're taking it at the wrong time. So these are some of the medications that we really think about when we think about red flags. And later in the presentation, we'll talk a little bit more about that. But we want to be especially aware of these medications with our older adult clients. So at this point, we're going to talk about two screening tools for substance use and alcohol. The first tool we're going to talk about is the CAGE aid. It's developed about 25 years ago, and it's been very well researched. And the CAGE aid is actually 4 questions that ask you about a person's alcohol or drug use. The original CAGE was asking about alcohol only, but the CAGE aid now includes drugs. So CAGE is actually an acronym, and we'll see on the next slide what the acronym stands for, but you can use CAGE to kind of remember what these 4 questions are. So before you ask the questions in the CAGE, you first ask your person, do you drink alcohol? And you also ask them, have you ever experimented with drugs? And drugs might refer both to illegal drug use and the use of prescription drugs other than how they're prescribed. So before you begin, you ask these 2 questions, because if the person doesn't drink alcohol at all and doesn't use medications or illegal drugs, then the screening is going to be it's not going to make a whole lot of sense. So this page shows you, this is the CAGE aid. So the C in CAGE aid stands for cutting down. And so the first question is, have you ever felt like you ought to cut down on your drinking or drug use? And your client answers yes or no to that. A stands for annoyed. So the next question is, have people annoyed you by criticizing your drinking or drug use? And they say yes or no. G stands for guilty, which is, have you ever felt bad or guilty about your drinking or drug use? And then the last question, E, is for eye-opener, which is, have you ever had a drink or used drugs first thing in the morning to steady your nerves or to get rid of a hangover or an eye-opener? So if your client responds yes to 2 or more of these questions, then that's considered a positive screening, and that indicates to us that he or she needs to be screened further for their alcohol or drug use. Now, for the purposes of our work, we are going to recommend that for people who have an issue with illegal or prescription drugs, you refer them to a healthcare professional for additional assessment. And that's because there are some screening tools out there that can be used for illegal or prescription drugs, but they tend to be pretty long and complicated, and they didn't seem appropriate for the purposes of the Division of Aging Services. However, there is a good, shorter tool for alcohol screening, and so we're going to go over the audit now. So just to recap, if your client scores positive, so 2 or more on the CAGE aid, and their issue is with alcohol, you're going to go on and administer the audit. Whereas if they screen positive for prescription or street drug use, you're going to refer them to a healthcare professional for further assessment. So the audit, we're going to go through the 10 questions that make up the audit now. And you'll notice that when we did the CAGE aid, you didn't ask anything about how much the person drinks or how often. The audit gets into more detail about frequency and amount of alcohol use. So for each of the next 10 questions on the audit, there's a number. And this number corresponds to the number of points for each answer. So at the end, what you're going to do is total the points for each of the 10 questions, and that will be your client score. So the first question on the audit is, how often do you have a drink containing alcohol? And if they say never, you skip to the question number 9 and 10. So anyone who's getting the audit in this case has already told us that they do drink alcohol. So that's not going to come up as an answer. But the next options are they're drinking alcohol monthly or less, they're drinking 2 to 4 times a month, they're drinking 2 to 3 times a week, or they're drinking 4 or more times a week. The next question is, how many drinks containing alcohol do you have on a typical day when you are drinking? So answer number 1 is 1 to 2 drinks. Answer number 2 is 3 or 4 drinks, 5 or 6 drinks, 7, 8, or 9, and then 10 or more drinks on a typical day. Question number 3 is, how often do you have 6 or more drinks on one occasion? And they can answer never, less than monthly, monthly, weekly, or daily, or almost every day. Question number 4 is, how often during the last year have you found that you were not able to stop drinking once you had started? And they can answer never, less than monthly, monthly, weekly, or daily, or almost daily. Question number 5 is, how often during the last year have you failed to do what was normally expected from you because of drinking? And their answer can be never, less than monthly, monthly, weekly, or daily, or almost daily. Question number 6 says, how often during the last year have you been unable to remember what happened the night before because you had been drinking? And they can answer never, less than monthly, monthly, weekly, or daily, or almost daily. Question number 7 is, how often during the last year have you needed an alcoholic drink first in the morning to get yourself going after a night of heavy drinking? And the answers are never, less than monthly, monthly, weekly, or daily, or almost daily. Question number 8 is, how often during the last year have you had a feeling of guilt or remorse after drinking? And again, they can answer never, less than monthly, monthly, weekly, or daily, or almost daily. Question number 9 is, have you or someone else been injured as a result of your drinking? So remember, when we were talking about diagnostic criteria, one of the categories of symptoms was physical riskiness, so doing things that are hazardous even though you know that you're impaired. And your person can answer, again, never, less than monthly, monthly, weekly, or daily, or almost daily. And then the last question is, has a relative, friend, doctor, or other health professional expressed concern about your drinking or suggested you cut down? And they have 3 answers here. No, yes, but not in the last year, and the last option is yes, during the last year. And this question is getting at how recent is your alcohol use an issue. Okay, so you've now asked these 10 questions, and you go through and you total up the points next to each person's answer, and the score can range anywhere from 0 to 40. Now, if this were looking at substance abuse issues in the general population, then we would use a cutoff of scores of 8 or higher, and we would consider that people who have an answer of 8 or higher have enough symptoms of problem drinking that we would want them to get further assessment. But for older adults, we have an even lower threshold. We actually use scores of 5 or higher for further assessment, and that's because of the issues we talked about earlier. We know that older adults have lower tolerance, and so even if they're answering and getting scores of just 5 or higher, we are concerned about their substance use. So why did we pick the Cage Aid and Audit? They're both self-report tools, but they can also be administered by a professional, and they're both brief. The Cage takes just about a minute to administer, and the Audit, even though I talked through it pretty slowly just now, it actually doesn't take very long to administer either. And it also gathers more details about the frequency and amount of alcohol use. So, you can tell from these questions that you actually have gathered a lot of information after you've asked your client about them. Both the cage and the audit are free and available to the public. These are some links with the Substance Abuse and Mental Health Services Association of America where you can access them. So here's the cage aid, and the audit is also posted on that website. And at this point, we're going to go through some frequently asked questions. Of all the subjects that I've done webinars for DAS, I think that this one may be the most sensitive. I think that substance abuse issues are awkward for people to talk about. People have a lot of fear and worry around substance use, either being discovered by somebody else that you're using substances or trying to talk to somebody else. So some of the frequently asked questions that come up: can an older person who's had problems with alcohol or drugs really change? That's a good question. What can be done to prevent prescription drug misuse? So we talked a lot about, how common prescription medications are and the effects it can have. What can we do to prevent it? And then the last question here is, what are red flags for someone using alcohol or drugs? So let's talk through each of these one at a time. Is somebody too old to change? If you have a client with substance abuse or alcohol issues, it's likely that you're going to try to talk with some family members about it. And some family members may be just as concerned or more so than you are as a professional. But others may not see it as a problem, or they might minimize the problem, or they might feel kind of helpless to do anything about it. So here are some common reactions of family members when you try to talk to someone about an older adult's use of alcohol or medications or street drugs. Quote, "I'm not going to take away one of Dad's less pleasures in life." They might say, "There really isn't much for him to enjoy anymore, so why shouldn't he spend his time drinking? Who does it hurt?" They might say, "That's just the way Mom is. Maybe this has gone on for years, and maybe there's been some, just feelings of hopelessness around someone's behavior." Or they might say, "This is just temporary. She's just doing that to get through her grief or insomnia or loneliness." So this question about whether an older person is really capable of change is important, I think. I think at the heart of a lot of these comments is some fear around whether someone can actually change, and if you're going to stir up an issue, could anything good ever really come out of it? It's interesting because I found it interesting to learn that older adults tend to do very well with alcohol and substance abuse treatment. They actually have the highest rate of success in treatment across any age group. Part of what is complicated for older adults is the medical aspects of treatment. A lot of treatment starts with detox, and detox can be more complicated for older people because they have more co-occurring physical health problems compared to younger people. But older people also tend to have more life experience and better ability to follow through with commitments than younger people, and this may be why their success rates in treatment are actually higher. There's also this belief that treatment won't work if we force someone to go. There's this idea that someone has to hit rock bottom before they can get treatment. What's interesting is that the research actually shows that 70% of people only seek help after some sort of intervention. And that's, not necessarily the full formal intervention that you might see on TV, but just somebody approaching the person and saying that, I've noticed that you've had an issue with drugs or alcohol, and trying to open the conversation around that. So in terms of willingness to go to treatment, they show that rates of recovery are actually about the same between people who went by choice and those who were court-ordered. So I'm not a proponent of forcing somebody to go, but I think it's important to know that people do need to have some sort of discussion and conversation around treatment, and also that they can do just as well in treatment even if they're being forced to go. So the takeaway here is that, yes, older people are capable of change, and they can do well in treatment, but that most people need some sort of intervention in order to even start to seek treatment. There's also a big difference between forcing someone to take treatment and asking them about treatment. As healthcare providers, social service providers, there are very few situations in which we can actually force someone to go into alcohol or drug treatment. But you are in a unique position to open conversations. So the most important thing to keep in mind is that talking about alcohol or substance abuse with respect and creating an opportunity for the person to seek further assessment or treatment is incredibly important. I think a lot of people are much more open to discussing these issues if they can do it in a dignified way. So when you're encouraging someone to seek professional help, here are a few phrases that I like. You can. I don't think there's a reason to beat around the bush around this, but I think you can ask questions in a non-judgmental way and in a sort of problem-solving manner. So, have you had trouble with alcohol or drugs before? So this question helps the person reflect a little bit, weigh in on what you think you're perceiving. I like this next sentence. Was there something or someone that helped you in the past? So that's helping the person start to think a little bit about their resources, think about, something that might help them. And if they're not able to come up with anything, this is maybe a good time to suggest a few things and just see what they think about it. And then, I think it's important to not try to get all of these conversations done in one sitting. If you discover that someone's having an alcohol or substance abuse issue, to go from discovering that issue to getting treatment in one conversation, it's just kind of unlikely. So, I like asking someone, would you be okay speaking to someone about what's going on? Or can we talk about this again because I'm concerned for this reason or another? So, I do think that it's possible to have these kinds of conversations in a fairly brief manner to show that you're concerned while you're also respectful of somebody. And I do think this is a really great opportunity for people to open up about something that's kind of an uncomfortable issue. So we talked about screening, we talked about further assessment. We're not going to get into a lot of different treatment options today for alcohol and substance abuse in older adults because we're focused on effective screening and getting someone to that first step where they get the assessment with a healthcare professional. However, I do want you to know that there is a wide variety of treatment settings that people can go to for alcohol and substance abuse issues, and they run the gamut from inpatient hospitalization to outpatient day programs. So a lot of this, of course, depends on someone's insurance coverage and also their financial resources. But there are treatment programs out there that run the spectrum that might fit someone's needs. And I also think we often underestimate the power of engaging someone in talk therapy. I think that someone is far more likely to take steps towards treatment if they're able to discuss it with someone who they consider a trusted professional. Sometimes when I'm working with someone who has a substance abuse or alcohol problem, that's the main thing that I focus on. Just, can we get to a place where there's a little bit of a longer-term relationship where we can build up some trust and we can keep talking about this issue over time. Trying to solve all of these issues in one sitting, it's just a lot to do and to try to do. So another of the frequently asked questions was, how can we prevent medication misuse and abuse? We know that our older adult clients are going to oftentimes have a ton of prescription medications. How do we prevent people from misuse and abuse? This slide talks about medication management and being engaged in someone's care. And depending on your client's circumstances, it may be that you're coaching your client to be engaged in their medication management. It might be a family member. If there's a doctor on your team, it might be kind of keeping the doctor in the loop. So number one is to carefully follow directions for medications and to take the time to ask about all the side effects. One of the issues that can contribute to medication misuse and abuse is not knowing about the side effects. And if you don't know about what they are, it's hard to monitor them. Letting doctors and pharmacists know about all medications, including over-the-counter drugs and alcohol that the person may be using. So again, I think it's just tough when you're trying to cover a lot of different health issues in a doctor's appointment, but giving someone a heads up around things that you're taking that the doctor is prescribing, but also the things that maybe they're buying at the drugstore, like Benadryl or sleep aids or painkillers. That's incredibly important information too. And I do think that we underutilize pharmacists. I think pharmacists can form really powerful relationships with their customers and clients, and they are also, experts that may be able to provide some education and intervention. Never taking another person's medications, you'd be surprised how many people talk about that, and especially if they live in a community with a lot of seniors. There is a lot of medication trading out there, but providing some education around why this could be harmful is important. And letting your doctor know if you don't think a medication is working. That's important because sometimes when people don't feel like the medication's working or working fast enough, they take higher doses of it. So instead of playing with the dosing of the medication or the frequency, it's important to let your doctor know that it's not working, and there may be other ways of adjusting or trying other medications that are more beneficial. And then again, just screening consistently. A lot can change after someone was hospitalized and they're on a whole new bunch of medicines, and screening regularly over time can help catch some of the issues that we've talked about today. Other tips in terms of preventing medication misuse and abuse, and this is a little bit more from the clinician or the service provider's point of view. If at all possible, to have somebody accompany the client to the medical appointment, because we all know that sometimes you hear one thing and the person hears another thing. So having another set of eyes, whether that's a family member or a friend or a professional, if that's all possible, that can really make a big difference. Bringing in all the current medications so that the doctors and nurses can look at them is helpful. We're constantly trying to reconcile medications and figure out what's current, what's not. And when you have someone who's on a dozen medications, it's really hard to keep track. So bringing in the medications themselves is helpful. Again, letting the clinician know if you're concerned about misuse. I do think that is very helpful when doctors or nurses get a heads up on what's happening at home. And as an aging services provider, you may be in a really unique position to do that. And then calling the medical office if you don't see improvement or if someone's getting worse. And also requesting an order for a home health nurse or a social worker. That could be another set of eyes that I think anyone who has worked in the home knows that there's a great deal of difference between how somebody is at home and how they are in a doctor's office. So requesting that the doctor write an order for a home health nurse or social worker, that can really kind of bring some realism to the person's care planning. So another one of the frequently asked questions are, what are red flags that we should look out for when it comes to alcohol or substance abuse? If you are seeing somebody have a sudden change in their cognitive status, that's considered a red flag. So if they're sort of all of a sudden becoming sleepy or kind of coming in and out of consciousness, that's a red flag. They could potentially be getting delirious due to medications, due to medication interactions, due to alcohol, or other things. So that's considered an emergency, and it would not be a bad idea to bring someone to a doctor immediately or even to go to the ER. If someone is feeling suicidal or if they're feeling violent towards other people, that's also considered a red flag. Depending on what's going on with someone, they may have a co-occurring depression. They may be having some mood dysregulation related to the medications they're taking. If someone is feeling violent towards themselves or others, that's also an emergency. That's also a perfectly appropriate time to call 911 or to take someone to the ER or a hospital. Another red flag is if someone's been recently hospitalized and they're now back home. As we all know, a lot can happen during hospitalization. Someone can go in on a bunch of medications. They can come out on completely different things. So that's a time when we want to be particularly aware of what's going on with someone's health. And then the last thing is medication changes. If we know that there have been some significant changes in medicines and we're seeing any of these other symptoms, I do think that that's considered a red flag and an emergency. So we kind of talked through this. Emergency treatment, you can call 911, you can go to a hospital or an emergency room, you can try to see a primary care physician for a same-day appointment. And then I've been using these slides in all of my presentations. There is the Georgia Crisis and Access Line, which is a 24-hour hotline of mental health professionals. So these mental health professionals do cover substance abuse, and if you find that somebody is approaching a crisis or in a crisis, you're not totally sure what to do, you can call GCAL and they will help with an assessment, and they can even send a mobile assessment team to somebody's home. It varies on how long it takes for the team to get there, but there is coverage throughout the state of Georgia at this point. And again, we've touched on this a little bit earlier, but some other people that you can pull into the care of your client if they're having issues with alcohol or substance abuse. Think about medical doctors, especially ones who might know your client well and have a good relationship with them. But also think about talk therapists. They can fall into these different categories of psychologists, marriage and family therapist, licensed clinical social worker, or a licensed professional counselor. These are folks that might be able to form a somewhat longer-term relationship with someone and really talk through all the complexities of what's going on with their alcohol or substance use. We know that, people may not change overnight, but change is very possible. And I personally believe that if they have a trusted relationship in which they get to talk through these things, they will feel more empowered, more in control to actually take steps towards change. So that brings me to the end of my presentation. I greatly appreciate you joining for this training on substance abuse screening, and I really respect the work that's done by the Georgia Division of Aging Services. You work with some of our most vulnerable members of society, and you do very important work in helping someone live their best for as long as possible. So I hope the information that we covered today will help you feel a little more comfortable around talking about substance abuse and alcohol disorders. And I really do welcome you to reach out to me if you have questions or comments around your older adult clients.
Okay, thank you, Jocelyn, for presenting this information to us today, and I'm sure that it's all going to be used and be very, informative and helpful in future screenings. I'd also like to take a minute to thank the audience that will be listening to this and watching this here soon. I'd like to thank them for joining us today to learn more about screening for substance use in older adults. I'd also like to remind everyone to please take the post-test that's going to be provided for this webinar. You'll be able to find that link to the test. Hopefully it'll be right below the link for this webinar. That's usually where they are. So whatever link you clicked on to get here, just look below that and you'll find a link to the post-test. And Jocelyn, did you have anything else to add?
No, I just appreciate being involved, and thank you so much.
Okay, and thank you again. And it's been a pleasure hosting this webinar with you. And at this time, I'm going to go ahead and stop the recording here.